Healthy Places Network's live discussion series on cross-sector strategies to improve neighborhood health and well-being. I'm Colby Daly, Managing Director at the network, and I'll be your moderator today. And today we will learn about how community development financial institutions, or CDFIs, and impact investors are collaborating across sectors to invest in neighborhood health and well-being. For the purposes of today's discussion, I am defining impact investing as investments made into companies, organizations, and funds with the intention to generate a measurable social or environmental impact alongside financial return. Based on that definition, we've asked for 4 community investment experts to discuss how they are facilitating impact investments, either by implementing or assessing innovative financial mechanisms to support health. You can read more about our speakers by clicking on the link in your chat box, but here is a brief overview. First, Emily Chen is the director of the Healthy Futures Fund, the Local Initiative Support Corporation, or LISC, and is based in New York City. With 20 years of experience in community development, community health, and affordable housing nationwide, Emily manages the Healthy Futures Fund program, a $200 million initiative formed by LISC, Morgan Stanley, and the Kresge Foundation. The fund channels its investments and grants to health clinics and affordable housing that uses the co-location and co-programming model to positively impact the social determinants of health in low-income communities. Ian Galloway is a Senior Research Associate and Oregon State Community Development Field Manager at the Federal Reserve Bank of San Francisco. Based in Portland, Ian is an expert on community development finance, pay-for-success financing, and markets that value health. He has written extensively on these topics and recently co-edited the Federal Reserve's recent book, Investing in What Works for America's Communities. He's also published several articles, including one in Health Affairs, Using Pay for Success to Increase Investment in the Non-Medical Determinants of Health. You can look at the November 2014 issue of Health Affairs. Vedette Gavin is the Director of Research and Partnerships at the Conservation Law Foundation based in Boston. And as a public health practitioner and catalyst for community change, she is focused on her career on eliminating health disparities in communities of color through community engagement and systems change. Among her current projects is an assessment of the Healthy Neighborhoods Equity Fund, a $30 million private equity fund that invests in high-impact real estate projects with a focus on community and environmental health and regional equity in Massachusetts. And finally, last but not least, Norah McVeigh is joining us today from New York City, where she is Managing Director of Financial Services at the Nonprofit Finance Fund, or NFF. She directs NFF's community investment businesses, which include national lending and new markets tax credit programs. She is responsible for the delivery and oversight of impact investing products, from origination to risk management, and leads new product and program development, capitalization efforts, and national partnerships. She brings over 25 years of community finance and impact investing experience and currently manages assets of $250 million. You can read more about community health investments by visiting buildhealthyplaces.org, but today we'll kick off the discussion with brief summaries from our speakers. Then we'll move right into questions from our audience. We will make this as interactive as possible today. On that note, thank you again for those of you who submitted questions prior to the event. Please continue to share your questions and comments using the chat box on the side of your screen or via Twitter using our hashtag #NetworkCommons. So I'd like to begin our discussion today by asking you all to share your insights on the way CDFIs and impact investors are working across sectors to improve community health. Emily, let's start with you. What is the Healthy Futures Fund, and what are some examples of the ways that fund has supported neighborhood health and well-being?
Thank you, Colby, for inviting LISC to participate with this amazing group of experts. So let me start off by saying something that was, it's a simple premise. The Healthy Futures Fund was created to help break the link between poverty and poor health. In our day-to-day work at LISC, with our field staff and community partners that span 31 cities and hundreds of rural communities, we experienced something that many of you would also understand, that the rates of chronic diseases continue to rise and plague low-income communities. So the theory was this. We thought if we could be more deliberate about connecting community development work that we know so well and health work, and then intertwine the two in the very same communities, we can improve the whole health of individuals and the community that we're in. So with this in mind, as you mentioned, Morgan Stanley, the Kresge Foundation, and LISC came together to form the Healthy Futures Fund. It is a $200 million investment fund that brings together equity, loan capital, and grants to invest in affordable housing and health center expansions. We focus on co-located and co-programmed projects to impact the social determinants of health. The first 100 million is now fully closed in 10 projects in 8 states, creating more than 400 units of affordable housing, co-located with health services, and the capacity to serve 100,000 individuals with primary care services. The partners recently announced another 100 million in capital is available immediately to expand on the work from our first fund. Now, Colby mentioned something in a past conversation that we had, that co-location does not mean collaboration, and I couldn't say it better myself. The way we're approaching it from the Healthy Futures Fund, coupled with the investment dollars, are grant resources and technical support to really help our partners on the ground to make sure their collaborations are optimized to benefit the residents, the patients, and the communities that they're in. So let me answer the question about the examples of ways that we have supported neighborhood health and well-being. Let me highlight a couple projects that we worked with. We love all of them, but I think these two are particularly illustrative of the kind of projects that tackle structural inequities in very practical ways. So first, we'll go to Brockton, Massachusetts, which is outside of Boston, and where a health center came together with a grocery store to co-locate and redevelop a blighted street corner in downtown Brockton. It brought very needed healthcare capacity as well as access to fresh foods to this low-income community. And what we love the most about it is the fact that this for-profit, nonprofit partnership came together to jointly implement nutrition programming that we supported in part with the Healthy Futures Grant. The other project I want to cite now is in DC, where we invested in the Conway Center that brought together housing, healthcare, and employment training all in one site adjacent to mass transit. We are at the Healthy Futures Fund working with a group in addition to providing a grant to help advance the programming that will allow synergies between all three elements that is located on site. Thanks, Colby.
Great. Thank you, Emily. It truly is an example of the Healthy Futures Fund is truly an example of innovative products out there investing. And we do have a write-up on our site, and I'll refer to it a couple of times, but we did a long-form essay on Medium about impact investing products and featured the Healthy Futures Fund. Ian, moving on to you. You're an expert on Pay for Success, which we all know is another innovative funding model that supports social needs. So can you tell us a little bit more about how Pay for Success programs generally work and why you think they're important?
Sure. Thanks, Colby. Can you hear me okay?
Yes.
So let me start with the latter question, why I think this is important. So I think we talk a lot about investing upstream in prevention, keeping people from needing expensive healthcare treatments or expensive incarceration or the rest. But we have a really hard time making those investments, and I think that there's a couple of really important reasons why that is, which are both solved by Pay for Success, otherwise known as social impact bonds, for those of you who are new to this. The first is it's really hard to make upstream investments because it's very difficult to predict when a program is going to work with a new population of people. So there's a risk component to this. These programs don't always produce the outcomes that we want them to. And the second challenge is that all of our money, or vast majority of our money, is tied up treating the results of having not made these investments in the past. So you can think of expensive incarceration, you can think of expensive foster care programs, shelters for homeless people, and of course, a vast majority of our healthcare system is treating diseases that could have been probably better dealt with before they manifested and became an expensive problem. So I see those as sort of the twin challenges that are keeping us from making the kinds of strategic upstream investments that will produce the outcomes that we really want. So how does Pay for Success solve that, and how does it work? So basically there's one major innovation with Pay for Success, and then there's a secondary financial implication that's important. The major innovation in my mind is the performance-based contract, which basically links a nonprofit social service provider with an end payer. That end payer could be a government agency. It usually is. It could be a state, a county, a city, or the federal government. Or it could be a foundation, potentially. Or it could be a health insurance company or any organization or entity that benefits from a particular outcome. So that contract links the nonprofit with that end payer, and in that contract, it spells out what is the outcome that we're trying to achieve, how long does the nonprofit have to produce that outcome, what are the parameters of how the nonprofit can operate in producing that outcome, and basically how that outcome is going to be measured, who's going to measure it, is it going to be compared against a control group, or is it going to be a pre-post analysis. All of that's really important and needs to be negotiated at the outset in that performance-based contract. But it's really important because it flips the way that the end payer, or the payer, excuse me, is paying for social services. Typically, we fund social services up front with the expectation or the hope that that investment will produce the outcomes that we care about in the future. That doesn't always work out, of course. And the innovation here with the performance-based contract is that money is held aside until that outcome can be demonstrated as having been created, and only at that point are the funds released and used to pay back the nonprofit for having accomplished those outcomes, created those outcomes. So, of course, you're probably thinking, well, this creates a financing challenge, this creates a cash flow challenge for the nonprofit, which is absolutely right, which is that second component of pay for success, the bridge financing, essentially. So these are investments that banks or foundations or impact investors make in nonprofits participating in pay for success contracts that basically provide them with the working capital they need to run their programming until they can create the outcome that triggers the success payment from the end payer. So it provides that bridge financing, but also importantly, it shifts the risk onto the private investor, because ultimately, if the nonprofit can't produce the outcome that will trigger the success payment, there will be no funds available to repay the investor their original principal investment or any rate of return on top of it. So those are kind of the two main components of pay for success, and I think we'll talk a little bit more about how they work later in this broadcast. But in my mind, the key innovation is the performance-based contract. It creates the need for an investment partner. But the beauty of this is it allows us to invest in upstream interventions that are difficult to invest in today for the reasons that we talked about earlier.
Great. Ian, yeah, paying for outcomes. It's a novel idea, but very exciting. I want to mention that the What It's Worth book, which was published by the SF Fed, is available online. And Ian, maybe can you give the URL for that?
So it's just whatworksforamerica.org.
Okay, so it's available there. And also, just to let you know, another Medium piece on Pay for Success and SIBS, the network published recently. I think that there will be a link for it in the chat box. Please take a look at that as well for more information about SIBS. So moving on to Norah, how about you? Like Emily, you work at a national CDFI, the Nonprofit Finance Fund, that has a Pay for Success initiative, among other programs focused on health. Can you tell us more about what CDFIs do and how NFF specifically has worked across sectors to invest in community health?
Sure. Thank you, Colby. I can talk, specifically CDFIs. There are many CDFIs across the country, probably more than 1,000 or so, and they range from whether they serve small communities, if they work nationally or not, what types of borrowers they work with, what types of products they provide, and what sorts of non-financial services they also provide to the market, whether that's policy or capacity building, those sorts of things. So there is a wide range, and they engage in a number of different ways to direct capital and to focus on improving health in communities. NFF specifically is We have about a 35-year track record supporting the nonprofit organizations across the nation, and we come at the work with a belief that community-based organizations are really vital to improving the health in communities and as vital partners to other players in the community. And so one of the things that we do is we provide financing, and that financing is both facilities financing, but we also recognize that a facility is often not the only thing that a community-based organization needs, that they also need working capital. And so it might be helpful to talk a little bit about some examples of what that means. And so on the facility side, we have financed a federally qualified health center that was purchasing property next door, that it needed to develop and consolidate some sites to serve more clients more efficiently. And then also working with not just the primary care providers, but others who are providing other related services. We financed the leasehold improvements of an organization called LA Kitchen in Los Angeles, which is preparing meals and working with providers of meals for elderly residents in communities. So it's really sort of cutting across the span of primary care, but a lot of the other social services that are being looked to provide complementary services in communities. And then on the working capital side, we also finance different organizations with different needs, and we really try to tailor the needs to the financing to what the needs are that they have. And so, for example, we have financed a federally qualified health center that had received a grant from HRSA to open a second site, and so they had the capital part of the financing lined up through that, but they really lacked the working capital in order to hire staff and put other systems in place in advance of opening to serve clients. And so we provided that sort of, we call it a growth capital loan to them with a lot of flexibility up front while they were ramping up, and then asking them to repay once they got to a reasonable scale. And then we also provide lines of credit, and as folks know on this call, a lot of the payment streams related to health are changing and shifting a fair amount, and it's creating a certain degree of uncertainty in the market. And so we have a client whose payment streams were originally coming directly from Medicaid, and they're now going through a Medicaid managed care organization, and they were anticipating fairly long delays in getting those payments. And so without wanting to interrupt service, they were providing them a line of credit to smooth that cash flow. So it's really looking at how the facilities and the working capital play together to meet the needs. One of the other places that I think CDFIs can play in this field, and where NFF plays, is helping to link other funders who may be interested in health and thinking about putting impact investing dollars or other grant dollars into the market. And so given sort of where some CDFIs sit as being sort of central and in communities, we sometimes help funders develop and manage those sorts of impact investing programs to funders who may not have either the built-in capacity or expertise to do that and need extra resource. So we can help sort of intermediate that capital in that way also.
Great. Thanks, Nora. Yeah, it's really, CDFIs, they're impact investors in their own right, and yet they also can play this important intermediary role linking private investment to social impact, low-income communities. So kind of a dual role there, facilitating the investments, which is really important. Vedette, you have a public health background, and you're currently assessing another innovative community health investment program called the Healthy Neighborhoods Equity Fund. Can you tell us more about the fund and what your research has revealed in terms of its potential impacts on neighborhood health and well-being?
Sure. Thank you so much, Colby. So the Conservation Law Foundation, located here in Boston, Massachusetts, is an environmental advocacy foundation that uses the law, advocacy, and markets to try to preserve healthy and vibrant natural spaces, which includes our neighborhoods. And so to that end, to harness the power of the market, we've created what's called the Healthy Neighborhood Equity Fund, which is a proof of concept fund. It's a small fund, $40 million, that provides capital which supports the development of mixed-use transit-oriented projects in urban neighborhoods. And we try to prioritize projects that have transformative potential for community health and quality of life in communities with significant health disparities and struggling economic growth. We prioritize projects that have features that are proven to promote neighborhood health and community health, things like including green spaces, being safe and active by design, providing retail that enhances access to healthy food while creating jobs. All of the things that we know from best practice are proven to support population health. We tied those criteria using a very intricate and complex scorecard to criteria for accessing the capital. And so we rate each one of the potential projects by how well rooted they are in these health promoting features, but also how connected they are to the community's own vision for how they would support a sustainable and healthy neighborhood, and also that residents and community stakeholders have been involved in the entire planning process. And we believe that marrying this community engagement and these health criteria for healthy features will help to create more of the types of development that will promote population health. And to that end, we've received funding from the Robert Wood Johnson Foundation to run a parallel study, which is more of functioning as a longitudinal evaluation to better understand the real impact on communities when transit-oriented developments are made. And so we've used an intricate set of metrics to try to ensure that our projects have the best potential to impact population health. But what we don't know is what actually happens to the lives of residents in those communities after the projects are built. And so we understand that when a new housing complex or a new mixed retail complex is built, it's not built as an island unto itself, and that actually it changes more than just the physical environment. It changes the social environment, it changes the neighborhood economy. And to that end, those other social determinants may be more of a primary determiner of who actually stays in the community. Those residents with poorer health who may be more marginalized tend to get pushed out and replaced by residents who already have better health and connectivity to opportunity. And so what we're looking to do is discover what are the driving mechanisms that create access to interact with the healthy features that are being added to the community. And for those residents who are already there, how does the changing physical and social environment around them mediate differences in perception and health behavior and ultimately health outcomes? And so we are in the planning phase of a 10-year study that will collect data based on health behaviors, health outcomes, development, scale, economics, and community cohesion. And we'll track those variables together over time to try to get a sense of what is changing and which of these variables take priority over the other in determining how residents access and interact with new healthy features in the neighborhood. And so what we are learning is to really hone in on, when we're thinking about choosing our measures, what is the time span that we actually expect to see these changes in, and what are some more upstream intermediary measures that we can choose that, taken together across all of these social determinants, will indicate earlier on that health and economy are both moving in a positive direction, and really trying to hone in on what particular segments of the population might experience those differences earlier or to a greater extent. And looking at, what are the differences in families, in marginalized populations, in young people, in seniors, which of those populations may experience differences earlier. So we look at things to try to say, okay, the health outcome we're looking at might be hypertension. What are some earlier things such as changes in chronic stress levels, self-efficacy, and even early health behaviors around how people are interacting with one another and interacting with their environment better as an early proxy to give an indicator that hypertension, heart health, cardiovascular health might be moving in the right direction.
Thanks, Vedette. It's so fascinating, and I think your evaluation is going to have huge implications for how we think about outcomes of these types of investments. We actually, the network has the Healthy Neighborhoods Equity Fund indicators in our Measure Up on our website, so I'd point you to all of that, and I know our team is posting links in our chat bar, so we can refer you to a number of resources that our speakers are mentioning. I also want to say, I know we're using a lot of terms that may not be familiar to all of our audience. The network, if you go to our website, we have something called a jargon buster, that gets to some of these questions about what is the social determinant of health, what is community development in a CDFI. So I refer you to that as a resource as well, just to help kind of cut through the language that all of us speak for these kinds of things. I know there are a lot of questions coming through. We want to get to those, but I want to ask each speaker just a follow-up question, if you could answer briefly for us so we can get to the audience questions. You know, as each of you spoke, clearly cross-sector collaboration is at the crux of your programs. And now I'd like to ask each of you to provide more details on the partnerships that took place and their implications for the field. Emily, let's come back to you first. The Healthy Futures Fund is a joint venture between different types of investors, a philanthropic organization, a CDFI, and a private bank, Morgan Stanley. Why these investors?
Right. You know, so in our history, we've worked a lot with different philanthropies and banks and partners on the ground. So in this case, Morgan Stanley, the Kresge Foundation, and Liz came together, really building on a long history of working together. We've done a lot of things together that allows us to have that kind of trust when we're diving into this area of quite complex of working in health through community development. And you know, that trust is really the foundation on which we take that leap. We've done a lot of different things together, like working on addressing the affordable housing gap in New York City, or really catalyzing the renaissance taking place in Detroit. So from that point, we said, we're going to get together, we're going to address the health issues in our communities with a community development lens, and we want to achieve scale. So the scale is a particularly important piece here, because I think you can do a lot of different types of work impacting health at different levels of investment. For us, it was very important to be able to have a national reach, to have the kind of capital in place so that we can have the scale we're talking about. So the first $100 million that came together, one thing we relied on heavily is bring on board a private bank like Morgan Stanley, who has a very significant and strong capital base. So they're bringing their capital to the table. Kresge, as a philanthropy, and in a role that they were really amazing at, is helping to seed innovations. Things that may be difficult to finance right off the bat. We need, I think somebody mentioned proof of concept. So they came, had the courage to come to the table with seed dollars to help finance that innovation. And then for us as a CDFI, we bring technical expertise in certain sectors and using certain financial tools to the table. And we also have a national network of community development professionals and groups that we work with. All of this together, very important to successfully launch a major national initiative like this. And when we look at this too, because we're all in it to have some kind of impact, what is the kind of return we're looking to achieve? And while we're also talking about real, valuable community assets being built, like the 400 plus units of housing, like the 100,000 more slots in terms of capacity to serve low-income people in terms of primary care services, we also know that health work is a long game, and we're particularly excited about the innovative partnerships that we incentivized and help nurture that can really be there to improve the community for generations to come. So that's a big part of the return that we're talking about.
That's so exciting. And I want to ask Norah, sort of along those lines, could you talk more about NFF's partnerships with healthcare systems and the outcomes of those collaborations?
Sure. I think the one example that probably best describes this is work that we're doing with Dignity Health in California. And so they're not only an investor directly into NFF and providing capital that we can deploy into communities to address a variety of health issues, they are also looking and using their capital and investing directly into projects. And so we are partnering with them on those projects, and we are both identifying projects for them that they can co-invest with us into, and they are also identifying projects and reaching out to us for additional capital too. And then there's a lot of cross-sharing around the due diligence and the way that we're underwriting and looking at the deals. And so I think with a hospital system that has a commitment to to place impact investing dollars into communities, but perhaps has a small team with which to do that. We're sort of a bit more of eyes and ears for them and a partner in sort of assessing those opportunities too. So it's a way that I think CDFIs can sort of intermediate that capital.
Mm-hmm. And lots of implications there for how others can get involved, how other health systems can get involved. Ian, moving to you quickly here, can you speak more about the successes and challenges of Pay for Success in general, and what you think the implications are for bringing health and other investors to the table?
Sure, happy to. So as you know, this is still relatively new. There have only been 11 Pay for Success projects in the United States. But it's north of about $100 million in total investment. So, you know, it's growing, and we're probably going to see quite a few more deals launch in the next year or two. So for me, the biggest success actually is that this has really changed the conversation about the role that the social sector should play. And it's really, I think, focused a lot of attention on outcomes as opposed to process, which has been historically how we've approached a lot of difficult, intractable social challenges. So I see just that shift in tone and conversation and focus as a huge success so far, you know, from this still relatively new field. On the challenge side, you know, I think first and foremost, the data piece and the evaluation piece and the definition of, you know, what counts as success is all really important. Obviously, these contracts you know, need to be very, very clear about what counts and what doesn't count, and who's going to measure that, and is it going to be compared against a control group? Is there going to be some experimental design component? All really important questions, and all really, really challenging things to consider. So I think that's been an important conversation that's been happening as these projects have come together, but it's a tough slog, and I think that it's an element of this approach that is not going to go away anytime soon. Probably for the better, because it brings, I think, a certain level of discipline that has been absent in the past. The other challenge that I've run into quite a bit actually is on the investor side. There's a lot of skepticism, which I think is appropriate in some contexts, about the role that the investor is playing in these transactions, and I think some concern that investors will be, you know, calling the shots about what the nonprofit ought to be doing with respect to their populations that they're serving. And I think those concerns are valid, and I think, again, going back to the contract, it's important that they be addressed at the outset. But I also want to educate the folks who are a little bit skeptical about this, that investors can play a really positive role in these transactions, and have been historically playing a very, very important role in community development finance. So this is not necessarily new. It's just a different application and a different role for them. So I think there's still some education to be done. With respect to the health opportunities here, I think that obviously the social determinants of health are a significant driver of the health outcomes that we see, and of course the healthcare costs that we see. So I see a huge opportunity to invest in the social determinants as a way to reduce those healthcare costs and improve health outcomes. The challenge that we've had, of course, is that the healthcare community, doctors, hospitals, etc., are not necessarily well equipped to make investments in social services that would address the social determinants. The beauty of Pay for Success, of course, is it shifts that responsibility off of the healthcare provider and onto a nonprofit with an investor partner. So it sort of, I think, unshackles the healthcare community to make investments in upstream determinants in a way they haven't been able to in the past. And then finally, on the investor side, bringing them to the table, you know, we spend upwards of $3 trillion a year on healthcare in this country. And if we can address the social determinants more strategically and effectively, we could significantly reduce those healthcare costs by billions, potentially tens or hundreds of billions of dollars. So I see that, and I think that is an enormous market opportunity for investors. So I think that as we move in this direction, and as those opportunities to address the social determinants as a way of reducing healthcare costs emerge, investors will come to the table naturally because they'll see this as a great investable opportunity.
That's great, Ian. Thank you. And it's a nice segue into a question I have for Vedette. And quickly, and then we'll open things up to the audience, open questions for the audience. But Vedette, your work speaks specifically to the role of partnerships, both in the execution and evaluation of these innovative financial mechanisms, really to support health. So can you speak more about the process for evaluating the health outcomes of community development investments and what you see the community engagement process as looking like?
Sure. So our research team that is developing the methods is interdisciplinary from its beginning. So we're bringing together housing, urban planning, health, environmental justice, transportation, academia, and community to understand what we consider to be health and how we would measure it in the context of a dynamic neighborhood system. And in that, the community partners are kind of that voice of authenticity and that measuring block to say, you know, do all of these things that we are articulating kind of land somewhere and make sense cohesively. And so we are engaging 9 different communities in the study across the greater Boston region. And each one of those communities has an anchor community development health or community organizing group that serves as the home for the research. And across those communities, each one of those communities has 4 community researchers who are the community anchor of the research team. And we're using a community action research or a community engaged design to allow those residents to articulate the way that they think development impacts their health. And we're holding that up against the causal pathways that we know of from literature or based on health impact assessments and based on best practices to say, here's how this experience is for communities. Here's what the literature says this experience is. What are the meaningful things that we need to measure in between? And so those community partners are very, very key also in bridging the data gap. Ian talked about how important it is to figure out what you're measuring and in comparison to who and for whom, who decides what success looks like. And so this way we're considering all the traditional metrics from a systems level that indicate that a neighborhood is healthy and vibrant, and taking in those meaningful measures on the ground for real people to say that, yes, indeed, this is what this means. And one of the challenges with that is that a lot of the data that we have access to through a health systems level is only at the zip code level. And there are several neighborhoods within one zip code, some of them more affluent and stable, others more transitional and developing. And so one of the advantages to engaging our partners and our residents in determining what those measures are is that they will actually lead data collection at the neighborhood level for metrics that we don't have. And so if we want to do a measure of self-reported anxiety or self-reported stress, community perception of walkability, bikeability, journals or stress monitors on residents, the residents who are designing that methodology have complete say in determining what those methods look like and how we will collect it and actually lead some of that collection. And then lastly, our partner organizations, at the end of each year when we collect this data, will receive this data in real time and be able to align it with their planning and development strategies to say, you know, what is our particular approach to urban development that supports health in this community, and what are the outcomes of that, so that we build capacity with each year. As we look at the data in real time, those organizations can then adjust and try to make their approaches better, since they are indeed the ones who will broker development in their communities, want to build capacity over time. And so we're bringing together disciplines, we're bringing together residents, and we're bringing together institutions.
Great, Vedette. Thank you so much. And you know, I think this conversation gets all of our juices flowing, and I think the questions coming will do that as well. So I'm going to ask our speakers to keep the answers as short as possible so we can get to a few of these before we sign off today. But I want to start with the first question for Emily from Marydale DeBoer. And the question is, are there types of project financing for healthy communities that leverages community benefit investment dollars?
Right, no, certainly, and that's actually something that LISC, along with others, I'm sure with Norah at NFF, have been looking into. You know, as we talk about Dignity Health, for example, and other foundations or health systems that's looking at this community benefits, just because of the dollar size that we're talking about nationally, and how that compares to let's say your typical pool of CDFI investments, I mean, we're really dwarfed by the amount of resources available through the community benefits pool. So for LIST, we're actually looking at working with different systems across the country, there's some in the Northeast specifically, to take a look at how we can come together, use those dollars to really impact healthy communities in that way. So certainly that is a very strong pool. I think we're all still looking for the best ways to work with it, and to have the CDFI world access those resources on behalf of the communities we work in.
Thanks, Emily. And I want to say there's also a case study on our website on the Vita Stanford initiative in Stamford, Connecticut, that also talks about a hospital using some small amount of their community benefit dollars to invest in local communities. So there are other examples of that as well, and I think they're emerging and growing. This next question is, I'll ask you, Norah. It's from Jason Pace, and it's about rural partnerships. The question is, what are challenges and solutions faced in rural areas, and how can we attract co-investors and financial resources in those areas? You know, that's a tough one, and something we're trying to address, get into those rural areas more.
Yeah, it is a tough one, and I would also see if Emily had any response to that, because NFF typically doesn't work in rural areas, and so we don't have a lot of experience in that, but recognize and know that it is challenging because of all the issues that were laid out in that question. But if I could refer that to Emily and some of the rural work that she's been doing, that might be more helpful to the questioner.
Sure. It's interesting. Recently, I was speaking with a health care group that works in a rural footprint, and we were talking a lot about this model of co-locating services, really working together, and we talked about some of the examples of projects that we have invested in, a couple of which I just referenced during the session. And what I got as a response is, very telling, and it's true that in rural communities, the co-location of services and access of services is a very different issue. And, where it might make sense for a grocery store to be co-located next to a health center in an urban area, and have that be the kind of partnership we're trying to innovate. Sometimes it's important to co-locate a spectrum of services along the health continuum for people. It might sound a little bit more traditional for us that's trying to break these barriers and looking at innovation, but at the same time, I think you have to be very cognizant of the things that's going on in those particular footprints. As of late, our rural LIST program is looking a lot at the issues plaguing the rural hospital community, hospital care system, and we're trying to figure out if there's a way for us to work with our partners on the ground to impact that. Just because, as you know, in those areas, the rural hospital service the stop for all services, and they range from primary care, specialty, and all sorts of services along the continuum, and it's a real problem right now that we're seeing that's impacting our communities.
Great. Thanks, Emily. This one's for you. I think we have time for 2 more questions. So Ian, in a minute or less, what are more examples of social impact bonds? Are there types of social problems that are easier to address, and examples of bridge lenders and investors that you can give?
Sure, happy to. And let me just say quickly that if folks want to learn more about these and dig into the details, I'd encourage you to go to a site that NFF hosts called payforsuccess.org, and you can find information on all 11 of the projects that have launched so far. So my sense of this is that the initial deals that have been done tend to be sort of, I don't mean this in a disparaging way, but sort of low-hanging fruit. Things that cost the system, the social system, the government, the healthcare system a lot of money, like incarcerating people. Because if you can keep somebody out of prison, you obviously save the criminal justice system potentially $40,000 to $60,000, depending upon what state you're in. So any nonprofit that's very good at reducing recidivism, for example, the rate of reoffending, could potentially save the government a ton of money. And we're seeing that as sort of the leading, I think, reason for targeting particular areas and not others, is those huge potential savings with relatively inexpensive interventions. The other areas that have been launched, or the other areas that we focused on so far with the other projects, the chronically homeless, foster care, kindergarten readiness, have all been part of Pay for Success projects thus far, and I expect this to expand significantly again in the next year or two. But those have been the areas that have rallied the most interest thus far, about 3 or 4 years into this experiment.
I'm going to close this out here, everyone, but I wanted to see if Vedette, if you had any closing comment that you wanted to make. I know some of the questions that were asked you actually got to in your earlier responses. So, but any last words from you?
I'll just echo Ian in thinking about measurement. I think the key thing is figuring out, is remembering we're focusing on the social determinant and for whom does life and opportunity improve. So when we're making investments, you spoke about early childhood education. That's a much more significant investment for children in the neighborhood than perhaps, you know, a greenhouse that grows lettuce. So that low-hanging fruit, really thinking about what's going to change the opportunity trajectory for residents in that neighborhood and how they will be able to actually access resources where they live, work, and play differently are really key for thinking about what measures matter most. I know that was a question that some people had.
Wonderful. Thank you all. So I want to thank you, our audience, for joining us today and the excellent questions. We are going to respond to questions that were not answered live through Twitter over the coming days. So look for those tweeted at you. Thank you for those. And I also want to thank again Emily, Ian, Norah, and Vedette for joining us today. It's wonderful to have your perspectives. This is an important piece to really changing the way investments are made for health and well-being in our communities. So we will keep you all posted on each of these leaders in the field that joined us today and developments that they're seeing and talking about as well. Please continue to share any lingering questions you have via Twitter using the Network Commons hashtag. We'd love to hear your suggestions for future events as well. There's a survey that will be sent to you shortly. Please do complete that. And if you missed any portion of today's discussion, we'll actually post it shortly on the Build Healthy Places Network YouTube channel. And please feel free to check out our website. We encourage you to do that, and Medium, where we are posting our essays, as well as our blog on buildhealthyplaces.org. And finally, if you're interested in learning more about cross-sector collaboration and would like to attend future events like this one, please do sign up for our newsletter, The Pulse, which is on our homepage. You can access it there on our website. We hope to see you on March 15th, which is our next Network Commons. We'll discuss early childhood and the role for community development. We'll be joined then by Jack Shonkoff from the Center on the Developing Child at Harvard, Jim Marks from the Robert Wood Johnson Foundation, and Nancy Andrews from the Low Income Investment Fund. So until then, thanks very much, everyone, and we'll look forward to seeing you next time.